Well, good afternoon. Thanks for the invitation. The aim of this presentation is to show the clinical interest of UBM in the diagnosis and management of glaucoma. You know, for diagnosis of glaucoma, we need a lot of information, and sometimes here in Europe we first think to primary open-angle glaucoma because here is the most common kind of glaucoma, but in different countries we have different prevalence of disease, like in China, in South Asia, Mongolia, and here we you can see that angle closure glaucoma is the most common kind of glaucoma. So it's useful to have information about anterior chamber and angle. We can do that with UBM, a technique used for imaging of the anterior segment of the eye, introduced by Poster and Pavlin, compared to a scan or B-scan. A technical problem. Compared to sorry.
Back on screen.
Okay. Okay. Compared to a scan or B-scan, we have to use a much higher frequency transducer to obtain the image of the anterior segment. With slit lamp and gonioscopy, we can also see and study anterior chamber and the angle. They are important, but they are subjective. And also with the OCT is possible to study anterior chamber, and the two techniques demonstrated agreement in measurements of the anterior chamber, but the main strength of UBM is its ability to visualize structure behind the iris, including the ciliary body and the lens. By using UBM, we can obtain more clues about the mechanism of primary angle closure, and a lot of trial and study use in methods UBM, like the system to study the primary angle closure. We can study depth, angle, iris profile, iris thickness, iris insertion, the lens. And in a case like this, when we have a narrow angle caused by a ciliary body cyst, we can follow the patient only with UBM. So when we have to use UBM, or we could use it, first, to better study a new diagnosed glaucoma, when we want to have information of the angle, when we have to want to establish the risk of closure of an angle. Second, we have a new diagnosed closed angle glaucoma. We want to study the pupillary block, anomalies of the iris, of the lens, a shallow anterior chamber. And even here in the secondary glaucoma, like in ephema, vitreous in anterior chamber. And for me, it's very important to use UBM before and after a lot of procedures for glaucoma, like a simple iridotomy or an iridoplasty or glaucoma surgery. What we are looking for, first, qualitative and quantitative information of the anterior chamber, parameters of the angles. When we have an hard and complete cataract, the relation between the cataract with the anterior chamber depth and the intraocular pressure. And at the end, a baseline to use after a treatment, an iridotomy, an iridoplasty, to control the efficacy of the treatment. I'm a Quantel user. I use this platform that is a VisuS. First, we have to acquire good images. So you see here the preparation of the 50 MHz probe that is simple, quick, simple. with this cap, sterile cap. We can use some filters. You see here the image of an iridotomy without filter, and the image with the color, or in black and white inverted. For me, here it's a good image. Or with this other kind of filter called emboss. Then we have a lot of glaucoma tools. Now we will see some of these. The first is the one called LV. It's a simple but useful tool. You have this line, horizontal, joining the two scleral spurs. That then you have this distance between the first line and the corneal endothelium. We can call it C1. And then the LV, that is the distance between the line joining the scleral spurs and the anterior pole of the lens. Well, when LV is more than 1/3 the distance between corneal endothelium and the horizontal line, we can have an occludable angle, like in this case, that is a phacomorphic glaucoma. Here we perform cataract surgery, but in this image you can see the shallow anterior chamber, the narrow angle, and the contact between
Questo era buio alla pagina. Ecco.
Okay. Between the lens and the posterior surface of the iris. Another case, LV here is less than 1/3 of C1, but the angle is narrow. Another tool is simple, is the angle measurement in degrees. Another tool is the one called angle recess area. And I find another tool is this one, the trabecular iris space area is this one. And it seems to be important to assess the aqueous flow capacity. In our daily practice, a question when we think that a patient could have a narrow or closed angle is to treat or not to treat. For me, if you ask an UBM, you can target the strategy of treatment, provide the documentary evidence of the need of treatment, and after you can repeat the UBM and see the efficacy of your treatment, like in these cases, before and after. In another case of after iridotomy, and after a small, very peripheral iridotomy, now to see the path between the anterior and posterior chamber, I applied some filter, color, and this filter. In secondary glaucoma, it's important, for example, in a case like this, a grandfather that told me that his nephew, only 5 years old, hit him with a roll-up newspaper. He had pain, a high intraocular pressure, and the anterior segment was this with an emphysema. And so I followed the patient at first only with B-scan and UBM, because here in posterior segment you can see only vitreous hemorrhage. And it's interesting, the UBM, because you can see only blood here, and here you can see blood that cover the anterior surface of the lens, but here you don't see nothing but blood. Here you see some that could be the iris, and even here you see the blood cover the anterior surface of the lens. You see the iris here, but not here. And after some days, a subtotal iris disinsertion become evident. But if you see the UBM, you see that was exactly from 1 and 2 blood and nothing else. From 2 and 3 the iris, the pupil dislocated here, and even here the iris. Only the end of the story with the cataract surgery and the iridoplasty and the results. And the suggestion to take your time, use UBM in glaucoma management, because we can add a value to our work and to our diagnosis. Thank you.